So much like with peds, here are just some general oncological terms. I also added neoplasm. It's kind of just another word for tumor. But typically, it's really more or less, they're used interchangeably. So I just wanted you, if you see neoplasm, kind of think tumor, as well as if you see tumor, think tumor. Both can be benign, which means it's what? Non-cancerous. And if it's malignant, it is? Our patho ranges, but the general consensus of tumor formation, cancer formation, is this mutation of the cellular genes, meaning that as our cells, which naturally do separate to regrowth, our skin's ever shedding or constantly growing new things, it's proliferating at an excessive rate. Therefore, it then becomes clumped together to form those tumors or neoplasms. So that is the general pathology of cancer itself, as well as the etiology. Is there always a cause for cancer? No. However, we do know that some things do increase it, like carcinogen exposure. What do you think is one of our biggest carcinogens people are exposed to? Smoke. Radiation, if they're working at a factory, excessive chemical factories, those kind of things. You have 3 different processes. So with initiation, this is the first step. This is where your DNA sequence starts altering. There we go. Again, this can sometimes happen for no known reason. So a lot of the cancers are idiopathic, right? We don't know why. Or it can be because there was an exposure to something that's triggering it. Then promotion occurs after either repeated exposure to these carcinogens or even viruses. We'll talk about that on the next slide. And it causes them to mutate, causes these cells to mutate. This is, in the promotion step, is where the tumor starts forming. As this continues to occur, we start having that metastasis. I can't speak this morning. I didn't really have any coffee or caffeine, so I'm doing great. It continues to grow, mutate, and spread. And then by the point that it is spread, we're in the progression mode. It is progressed. And that's where we start getting into the staging of how severe is this cancer.
So the 3 is initiation, promotion, and progression?
Yes, those are the 3 stages. So initiation is like where that first step in the DNA alteration takes place. Promotion is where they really start to mutate, and by progression is when it is fully spread and metastasized. So some of our risk factors, y'all already said one of the biggest ones, smoke, especially tobacco smoke. Smoking, you're going to see this probably about 15 times at least on almost every single one of these cancers. Risk factor, smoking. Obesity is a large. Overweight, obesity, your book uses this kind of, they say overweight or obesity, but just think being overweight can increase your risk factor, as well as some oncoviruses, meaning some viruses that can cause cancer. Anyone know of one? Epstein-Barr virus. What is that one? What do we call that? What's the disease that it? Mono.
I think it's human Papillomavirus.
Human papillomavirus, HPV. We'll talk about that as we get close to the reproductive cancers. We've seen a lot less of this due to the vaccine now. As well as even patients with HIV because their immune system is so weakened that they have limited defenses. If you're exposed to radiation, chemicals, sometimes it's just genetics. We know family history increases your chances of a lot of cancers. If your mom had breast cancer, you are at an increased risk for breast cancer, especially if the BRCA gene is available. Again, we will talk about the specific ones as we get there. Talk about diet, some hormones, estrogen, progesterone, testosterone can increase the risk, as well as age. The less than your immune system is, the weaker your immune system is, the higher chances you will have cancer or develop cancer. Not a guarantee, just an increased chance. Here's a slide. It's also in your book. I'm not going to read this for you. It's just kind of showing the different types of cancers that occur between males and females and the ones with death. So you can see up there, lung cancer is one of the top deadliest cancers, etc. Again, y'all can kind of read that. I'm not reading it to you. It's just for your own little hooplas and knowledge. This next slide is a repeat slide. Y'all remember it? So what is stage 0 or in situ? You see, what does that mean?
No cancer.
There's not much growth.
Yeah, so we start seeing that there may be some cancer cells, but it's not really formed a full tumor tissue, right? Stage 1, tumor's there, it's small. Has it spread? Yeah. Stage 2, it's spread, right? And by stage 3, it's in the lymph nodes, spread. And do we think stage 1 or stage 3 is worse? 3. I know I'm asking y'all questions, obvious questions. And by stage 4, it is advanced. It has spread to distant organs, not just nearby organs. A lot harder to treat, a lot more aggressive treatment coming their way. Again, we already talked about this. This is, like I said, some of these are just definition slides. Metastasis, meaning it's changed, it's grown, it is spread, right? Whether that is in the blood, lymph nodes, or to another organ from its place of origin. Make sure y'all read origin versus organ. Place of origin where the cancer originated, new organ, and a new distant place. Here's just a picture. Anyone know what body part we're looking at there? That is a breast.
Oh. Oh, yeah.
That is breast cancer. Like I said, I had to guess one cancer at least that you will encounter some point in your career. It'd probably be between lung cancer and breast cancer. This is actually after a mastectomy, but it's still there. When they have, these are gnarly wounds. Let me tell you, I have some stories about wound care for some breast tumors that erupted through the skin. So this is just pictures also in your book, but yeah, you can sometimes see it once it pops through. Most common cancers, men, prostate, lung, and colon. Females, breast, lung, and colon. I don't have much to say about that slide. prevention, early detection, and regular screening. We will talk about, you may talk about them also in reproduction with Ms. Lewis, but we're going to go ahead and talk about it when we get to breast cancer in this chapter, as well as testicular cancer for testicular self-exam, on how we should be educating our patients to do regular exams, as well as when we start doing those regular screenings like mammograms, etc., pap smears. Genetic testing is going to typically be due to something's telling us to pursue it if there is a family history. So let's take breast cancer again. If they have the BRCA gene, mom had breast cancer, is really concerned for her daughters. She goes and gets tested, finds out she's positive for the BRCA gene. They can then test her daughters. And from there, if they find out that they have the BRCA gene, they may elect to go ahead and have a mastectomy, a double mastectomy done to cut off the breast tissue to decrease their chances of developing breast cancer. Healthy lifestyle, manage our weight. We like to eat good foods that are high in folate, that folic acid. Good fruits and vegetables, as well as we have seen that vaccines like for HPV have helped decrease our chances of getting cancer. I've seen this before, some of our warning signs. Think caution. First, change in bowel or bladder habits. Can we always see cancer growing inside of our body? No. So it's listening, watching, listening to your patients, having them listen to their body. All of a sudden, they're excessively constipated or diarrhea, and that's not their normal. They may need a colonoscopy. Let's go look at what's going on. They stop urinating. If there may be all of a sudden some retention. Might have a tumor in the bladder. A sore that does not heal. High chance. I think we talked about this a lot with skin too. Unusual bleeding or discharge. This could be in bowel, bladder, skin, sputum, etc. Thickening or lump. They're doing, they're touching themselves, something like that. Feeling their abdomen. Something's growing that should not be growing if they're doing a breast exam. Indigestion or difficult swallowing. Obvious change in warts or moles. If we see that, what cancer are we thinking of most likely? Melanoma. Or a nagging cough or hoarseness. So think caution. Warning signs. Again, a repeat slide for y'all. CBC. So what do you think we are looking at for CBC? White blood cells, red blood cells, lymphocytes. We could be looking at platelets, hemoglobin, especially if we're thinking of some of our blood cancers. CMP, what do you think we're looking at? Liver, kidney, if it's either from that place of origin or it's metastasized and affecting those. One of the other ones we also might look for is albumin. What does albumin tell us? Good job. A lot of it is our protein abilities. Albumin can be a high indicator of their ability to show us how they are nourishing their bodies, if they're able to continue to nourish their bodies. So it may be something that we are tracking, especially if someone is already going through chemo treatments and they're having excessive nausea, vomiting. They're not able to keep anything down. If the body is weak, what is protein again? What do I call it? It does what? It's our
building blocks.
It's our building block. It's what helps us heal our tissues, etc. It's our building blocks. So if we are not having good protein intake, we're not processing protein, are we going to be able to heal?
Yep.
So albumin will be a good one for us to look at. MRIs. we use a lot for gold standard for CNS, as well for tumors of the central nervous system, as well as helping to stage lymphomas or even other tumors. CT, y'all can read this. CT helps show the shape and location of tumors, as well as PET scan does the images of tumors and that says cell activity. Ultrasound, this is one of our least invasive things. It's something that can be done fairly quickly, easily. And it helps to differentiate between fluid-filled cysts or tumors, or even blood flow if the tumor's cutting off blood flow. And biopsy, that's typically our staging, right? If we believe there's a tumor, we get a biopsy to further stage. We look under the microscope to see the cancerous cells. Someone far smarter than me does all the lab work. Lumbar puncture also helps with some tumors of the central nervous system, like leukemia or lymphoma. We want them in that tight fetal position. They're going to insert it into the between the spine and between the vertebrae. So always think the back needs to be curved. Watch out for that post-lumbar headache, meaning that cerebral spinal fluid is leaking. Bone marrow, where is the most common site we get it from? The iliac crest, the hip. You can get it from the breastbone, but 9 times out of 10, it does come from that hip, that crest. You can see I use this slide. I'm an adult, not child. Again, y'all have had this slide before. It's not I told y'all I'm reusing them. The same thing goes. You're going to help put them in position and make sure that you hold pressure for at least 5 to 10 minutes. And in case y'all didn't know, you can, just like you can become blood donors, you can go donate blood. You can also go get registered if like cancer or something that really hits home to you. And you can actually sign up to put your information in to be a bone marrow donator. So if they find out you're a match and someone needs it, you can go donate bone marrow, just in case you're ever interested. This is just a little quick thing. So surgery is going to be depending on the site of the tumor, of origin especially. A lot of times we try to use it for curative. Oftentimes we call this like a debulking procedure, meaning we are trying to take the bulk of the cancer out, of the tumor out. As well as sometimes we do palliative surgery. So that kind of contradicts itself. When we think palliative, we're just focusing on comfort. But if the tumor is pressing on their airway and they can't breathe, is that a very comfort? There's only so much things we can do. Sometimes we will do palliative surgery. It's not curing them. Maybe the tumor is stage 4, the cancer is stage 4, it's progressed, chemo is not working, but we can still go in and try to remove some of the tumor to not press on their airway so much to treat the symptoms. As well as when we do surgery, we oftentimes try to remove the tumor itself for symptom based, as well as if we're not doing palliative, we're doing treatment surgery to remove the cancer, treat the cancer, as well as it leaves it open for the chemo and radiation to fully take force. So kind of think if you're trying to treat something this big, that's really hard, right? Versus if I take this out and now you only have to treat this area, it's a lot easier, right? Got good. Radiation. Ultimate goal is to destroy tumor cells, and allow the normal cells to regrow and repopulate. We have those different types. I'll quickly run back through them because I know it's been a couple weeks since we've done cancer. So direct radiation, most effective. It is basically like a dartboard target. It's targeting those cancer cells directly, most effective. (3D) conformal radiation. This is where a high dose of radiation is delivered, typically using a computer, with a very tight margin. So therefore, the healthy tissue surrounding the tumor only receives a low dose amount of radiation. Hyperfractionated radiation delivers 2 radiation treatments per day for aggressive and fast-growing tumors. So with hyperfractionated radiation, they will have 2 radiation treatments per day using for those aggressive and fast-growing tumors. Let y'all catch up for a second while I take a sip of water. Proton heavy particle therapy delivers maximum radiation energy. Oftentimes, this is the one used for a lot of our brain cancers, like medulloblastoma, retinoblastoma, or gliomas, so brain cancers. Brachytherapy, this is where we insert a radioactive device into the tumor bed, and it emits radiation over several weeks. And the CyberKnife radiosurgery uses computers, robotic arms, and even cameras to deliver high beams of radiation, oftentimes for brain or spinal tumors. So they use computers, robotic arms, cameras to deliver high beams of radiation, typically for very specific areas like the brain and the spinal cord. Side effects of radiation. Guess what? Fatigue. Yay, it already starts, that word. Nausea, vomiting and anorexia can also occur with radiation. Mucositis, we'll also see this mucositis / stomatitis. We see that for both radiation and chemotherapy. What are some of our treatments for that one? That's normally a big one. What do we want to tell them? Y'all remember? Try to keep their mucous membranes hydrated. Avoiding acidic things. anything that's spicy, hot, cold, excessive hot or cold. Not saying warm or cool, I'm saying hot or cold that are gonna irritate those membranes. Do we want to use a soft toothbrush or a hard toothbrush? Soft, if it's real bad, we even maybe saying the little gummies, little swabs, oral swabs, instead of even a toothbrush. Think anything that's going to irritate that lining, again, spicy foods, acidic things, we're going to want to tell them to try to avoid it. Xerostomia, what is that? Y'all know?
Dry mouth.
Dry mouth. So smart. We may have skin reactions. Do we want them to wash off our markings?
No.
No. Should they use scented soaps?
No.
If they use soap, it's a mild soap. Typically, we tell them that specific area, just water unless specifically told by the doctor. If they are going to wash with soap, it's a mild soap. Do not wash off our markings. As well as they still should be cautious of using scented soaps, lotions elsewhere. And we may start seeing bone marrow depression. If we see bone marrow depression, what's going down? Red blood cells, platelets, even possibly white blood cells, right? How do we help patients with fatigue in general? Lots of periods of rest, right? We don't want them to push themselves or exert themselves too much.
Patient clustering care.
Sometimes clustering care. So if they're already going to be up, try to do this instead of getting up, going to bed, getting up, going to bed. Good job. With radiation, we want to be aware of the time that they started. Sometimes this means that we keep our distance. Why is my slide? It's going to depend on the radiation used. So if you are going to work on a cancer floor, you need to be aware of when they got the radiation, how long you're spending with them, as well as the distance. If you need to stay in their room, have a whole conversation about education, you probably want to stay a little bit farther away, or at least wear protective gear. Sometimes these patients are told about be careful of their bodily fluids. That includes spit, or urine or feces. They may need to flush the toilet twice if they cannot have their own toilet at home. What kind of apron would we wear for lead? Good job. So chemotherapy, much like for children, again, it's a repeat slide. We are going to do antiemetic medications. We know nausea, vomiting is a very, very common side effect for chemo. How soon should we do it? Give the antiemetic?
30 minutes before.
30 minutes before. Push fluids as much as we can, specifically oral hydration. If we have to do IV, we will. You have to be trained to give chemo. It will need a 2-nurse authenticator and wear the appropriate supplies. If a spill happens, do you just automatically drop a towel on it and clean it up? No. You have to clean it up according to whatever that specific chemo is. I'm going to talk about the extravasation and that's the next slide. Also here, talking about bodily fluids. Again, this is all kind of repeat, so be careful of that with radiation and chemo. You all already have this slide, just the different ways to administer chemo. What do we see is the most common tube normally?
Oh, the board.
IV, so a port, but it's still going to the blood system, right? Intravascular.
I figured it'd be like oral.
I said top two, and the other would be oral. Yeah.
And how to pick?
Huh?
And how to pick line?
So IV would intravenous would be PICC line, port. Most likely we're not getting it through peripherals, so make sure you're watching that kind of terminology. You can do it all these other ways. But those will probably be the unless you end up working very specifically on a chemotherapy floor, or oncology floor, those will probably be your top two. If you're with me, for like clinicals, there are nurses up there that are chemo trained, so they will have chemo patients sometimes, so I don't think anyone has gotten to see it yet. They haven't. I've known they've had a couple patients, but I haven't seen it. But anyway,
Side note, on a Candler, on the med surg floor, you have to be chemo certified to be charge nurse.
yes, I think I did know that. Or I had picked up that they all were. That's also for St. Joe's, I believe.
Cool.
Dang, hospital system. Y'all can read that. So again, we have that bone marrow depression. So what is nadir? What do we call that? So nadir is a period of time, typically about 7 to 14 days after the start of chemotherapy. So nadir is a point of time, about 7 to 14 days after the start of chemotherapy, where our blood cells plummet, meaning that that point of nadir is when the patient is at the highest risk for infection. The point of nadir, 7 to 14 days after chemo, highest risk of infection because their blood cells plummet. So this is going to include education for the parents. If they're like, oh, we have this trip planned, right? We're going to take them to Disney World. Or I guess we're talking about adults. So we're going to the beach. Yay. Maybe let's wait till after that point, right? Exposing them unknown pathogens, as well as just being cautious of who comes in the house, if someone's sick, etc. So leukopenia, what is that? Low what? White blood cells. Thrombocytopenia is low what? Platelets, and anemia is low what? Red blood cells. We've talked about nausea, vomiting, and diarrhea. We said for stomatitis, mucositis, avoiding those irritating foods, spicy foods. What about mouthwash? You think mouthwash is irritating? Yeah, especially alcohol-based ones. Do we want them to have super hot or super cold items?
No.
No, good job. We talked about soft swabs or soft toothbrushes. Should they keep smoking?
Probably not.
Hopefully not. Are they going to? Is the real thing? Yes, they probably are. I'm not judging anybody, I promise you. I just find it's not funny because it's never funny. Let me be clear. This is not a funny situation. But you will often see, which I'm glad they stopped. Like, it's always better. But you will have people who have smoked for 50 years of their life get lung cancer, and that's like the wake-up call that they need. And they stop. And you're like, how many times have we had this conversation for education? I'm glad they stopped. Let me be clear. It's not funny. It's just a correlation that I've seen so many time and time again. Like, you have this conversation over and over. Even if they're COPD and they have oxygen and you've educated them, but it's like they get the lung cancer and that's their I'm a stop moment. Good for them. Glad they stopped. But I don't know why. Personal experience with that. Let me be clear. Not me. let's see, dentures. What if your patient has denture and has stomatitis? What do you think we're gonna tell them? We're gonna tell them to stop wearing them altogether?
No,
We're gonna still want them to wear, especially if it's helping them eat, right? But we wanna tell them to what? Keep them clean first and foremost, right? And make sure they are taking them out at bedtime with proper care to their gums and the dentures, keeping them clean. Nausea. What are some medications we give for nausea?
Dantatron, Zofran, promethazine.
Yep.
Colchicine, Reglan.
Gotcha. Ondansetron, Phenergan, Zofran, Compazine, etc. We give it 30 minutes before, right? If they are still nauseous even with the medicine, how do we want to break up their meals? Do we want to give them 3 large meals? Small little meals at a time, right? Kind of that blander diet. Nothing that's going to irritate their tract. If they have I can see the word. I can't say extravasation. Yeah. Anyway, that word. I can see it. I can't see it. My tongue's not that extravasation. Yeah. Y'all know me and my ability to speak. It's gonna bother me now. Anyways, I'll keep moving for the sake of time. It's gonna bother me that I'm not able to say it right. When I randomly blurted out of your break, just don't pay attention to me. So this, what is this? What happens? This is when a extravent goes into the tissue, right? It's for whatever reason no longer going into the bloodstream, into the vessels. So, and if it is chemo or an extravent, which is highly, highly toxic, can be necrotic, can cause tissue death, like chemo, because what is chemo doing? It's killing cells, right? This can be very, very bad. So if you are giving chemo, whether it's in a PICC line or a port, unlikely that you're giving it through a peripheral IV, but if it is an emergency situation, I have seen them. Not chemo necessarily, but like levo, which is same thing. Not same thing, but it's toxic, necrotic. You first want to stop the infusion, assess the site. Patients may complain of severe pain in the area, burning, stinging. You may see this discoloration because what's happening is healthy tissue is dying. We may want to give fluids to help wash out that area. If it is possible to, again, we would not be doing it, but if it's possible to extract some of the medication, we will. We do have a couple antidotes. I'll give you 2 examples and I will spell the meds for some of our chemos. So if there's an antidote available, we'll give an antidote. The first antidote is dexamethasone. I'm gonna spell it DEXRAZOXANE. So DEXRAZOXANE. We will give this for the chemotherapy doxorubicin. I'll spell that one too. DOXORUBICIN. It's one of our common chemotherapies. second antidote, HYAL URONIDASE. So HYAL URONIDASE. And that's for vincristine, which is another common medicated chemo, which is spelled VINCRISTINE. And another one of our nursing indications can be elevate the limb.
Did you say B or B?
V. Yes. V is in violin.
Missy, you said the antidote dextromethorphan and the DOX1,
Yes.
that's two.
So the dexaroxin is an antidote for the doxorubicin. So your two antidotes are dexaroxin and the hyaluronidase. Whoever named medications, I have words for them.
Can you repeat the last chemo for me, please?
The last
Chemo.
chemo, vincristine, VIN.
You said
CR. VI as in violin, yes. VINCRISTINE.
So the Dex one was the antidote are types of chemo?
So dexaroxone is for the doxorubicin, and the hyaluronidase is for the vincristine. So two antidotes for two chemos.
Okay, thank you.
And this is when the chemo is no longer going into the bloodstream.
Yes.
Now it's affecting the health.
Yeah, this is for the extra passive, yeah. Our cell transplants. So we know we're gonna hit them with a high dose of chemotherapy to first kill the cancer and suppress the bone marrow. And then we will resupply. Since I sent y'all a whole fun little handy doodad, auto means it comes from cell. We have very little risk with that one associated for rejection, right? Because it's your cell. Allogenic comes from somebody else. So we have to make sure they have the right markers, right? That they're a match. And then we have umbilical cord. Again, that one sometimes has ethical concerns because it's coming from a fetus. Again, these are repeat slides, so I'm not going to harp on them. Just always watch for any type of rejection. I'm gonna get through the treatments and then I'll give y'all a break. Again, immunotherapy is repeat slide. I'm not getting through this. This is sometimes used an adjunct as alternative treatments. Chemo is still the preferred. Immunotherapy does not work for every cancer, for every patient. But we do this to try to kind of help bolster the immune system to then fight the tumors. So here are some of our common chemotherapy medications. Just so y'all see them, these are very broad. They treat a multitude of cancers. So we have methotrexate, that doxorubicin, citrabine, and vincristine. I just put them up there so if you do see them, know that these are chemotherapy medications. One thing we may see with methotrexate, is we may see a decrease in their folic acid because the methotrexate will block the body's production of folate. So we may they'll probably need, supplemental folic acid or a diet that's very heavy in folic acid. Yes, so methotrexate will block the body's natural production of folate. So we will probably supplement them with over-the-counter folate or folic acid. Or want them to have a diet heavy in folate and folic acids. Folic acid. What you got?
It blocks the what?
Body's natural production of folate. Methotrexate blocks the body's natural production of folate. So here are some other medications that we may use for some of our treatments, or not treatments, treatments of signs and symptoms, I should say. Allopurinol. What do we think when we say allopurinol? We think gout. What is gout? An increase of what? Uric acid. So uric acid is a waste, right? So if we are destroying a bunch of cells, what do you think we're producing in the body? A lot of what products? Waste products, right? Including uric acid. Sometimes we will give a patient allopurinol to help combat that increase, inhibit that uric acid. Let's see if y'all remember way back from blood and lymphatic. Filgrastim, Neupogen. It tells the bone marrow to help produce what? White blood cells. So FOE and alpha tells the bone marrow to produce what? Red blood cells. So filgrastim. If we see Neupogen, what do we think often with like? Neutrophils. Yeah, neutrophils. So think white blood cells, it produces white. FOE and alpha, think erythro or red. I want you to look at ondansetron. It ends in citron, right? So if you see a medication that ends in citron, you're probably thinking it helps treat what? Nausea and vomiting. And as well as Phenergan, Compazine. There are quite a couple medicines. There's Reglan out there. Reglan, some doctors love it, some doctors don't. But are typically, if you were to say like a standard set order, ondansetron is most likely going to be the one. The palonostrone is a great nausea vomiting specifically for chemo. Not saying it's always.
Which one?
The palonostrone, the second one, is specifically for chemo-induced nausea. We just have these pesky things called insurance companies. And they typically want you to go with whatever is the cheaper option. And we will often have to use the more generic, tried and true, broader things before you're able to get down to the specific. So that's why I wanted you to see the citron. So even though it's a new med, you know that it does what? It treats nausea and vomiting. Pain control says controlled substances. This can be a very sticky situation amongst families. I'm gonna let you know right here and right now. Most of the time during chemo and cancer treatments, they are a little bit more relaxed with it, but there are people whether the patient themselves or family members had addiction problems, can be really concerned with narcotics. Or the side effects. Well, I give Mima her oxycodone and then she just goes to sleep and I want her up and doing things with me, so I don't give it to her because I want her to be awake, like I want to talk with her. Okay, that's great, but Mima's also in a lot of pain. So you have to do a lot of education, as well as normally narcotics, we know they have what side effects? What are some of our common side effects? I just mentioned one, sedation. Respiratory depression, confusion sometimes, right? Can cause hypotension. But constipation is a big one. So we want to educate them, but oftentimes as they kind of build up a little bit of a tolerance to it, we may start seeing that sedation kind of decrease. So it can be an education of, hey, we need to make sure that Mima does get this for her pain. That, you know, as she gets it on a more regular basis, and she needs it, that we may not have some of those sedation kind of things, and Mima may be talking to you without the pain in a couple weeks. As well as patients and family members need to be educated. We tell them most of the time they're given PRN, right? Anyone in, I'm not asking you, but think about it. If you or your someone you love has had surgery. If you wait till you're at a 10 out of 10 pain, do you think that medication is going to be super effective? No. So 10 out of 10, you take that oxycodone, we may get them down to 7, maybe, if we're really lucky, 6, in those 2 hours. We're then chasing it. We're having to chase the pain. So then they're going to have to take it more regularly. Versus a lot of times if you kind of help them set up a schedule for it, and I'm talking about if they're at home, at the hospital, you have to follow your orders. They have to, you know, y'all seen the MARS where it's like patient rates their pain. You want to give them the oxycodone. They have to say it's in an 8 out of 10 or whatever. But I'm saying if you were end up working in an office or anything like that, a lot of education. Sometimes staying ahead of the pain, telling them to make sure they kind of get on a little bit of a schedule. Don't wait till the pain is a 10 out of 10. If Mima's goal is to, she's like, you know, I got the arthritis, I'm always at a 3, that's where I live comfortably. And she starts seeing it's like a 4, 5. Let's take it before it gets to the 10 kind of thing. Don't wait till they are laying there miserable. So a lot of education comes with this because there are a lot of feelings about it, especially if you end up doing the end of life care with hospice and morphines. We want to worry about their comfort as well. As well as the Mima's in 10 out of 10 pain, she may not want to talk to you anyways. Sometimes we have to put it like that. Steroids, magical drugs. Typically Decadron, prednisone. We also have Solumedrol. Great medications to help, a non-narcotic way to help with pain, because it does what? What do steroids do? They decrease inflammation. So they are also highly effective for a lot of our bone cancers. So a lot of times our narcotics, our oxycodone, morphines do not work super well on bone cancers.
I thought prednisone and similar steroids caused osteoporosis, and
They might. I'm talking on the palliative side at the
Yeah.
end, like we're not worrying about Mima breaking a hip kind of thing. because a lot of that pain is gonna be inflammation based.
Fair, okay. I
Um,
just figured that was more for soft tissue, not.
yes, in my practice, that's, like I said, this sounds so bad, I don't get this reported. I worked for hospice, I worked as a nurse practitioner for hospice, I worked with a lot of narcotics. So to say, I saw a lot of that, which, so speaking of, let's have a little blurb, it does still apply, a lot of my cancer patients are on it. Patches, fentanyl patches, right? How do patches work? Huh?
Rotating every 3 days, you have to avoid heat, you have to wear gloves when you apply them.
Yeah, so they work for 3 days. So they release over 3 days. So first, our education for patches. First 12 hours, that patch,
No.
fairly ineffective. So, again, education. Mima, I'm gonna put this patch on you. And the family be like, I gave her the fentanyl patch. Why isn't she in pain? Calling us. Mima's in 10 out of 10 pain. Help! She is screaming. She's in agony. Well, have you given her any PRNs for breakthrough? No, I put the fentanyl patch. What time did you put the fentanyl patch on? Well, I did about 2 hours ago. Minimally effective. So tell them for at least the first 12, if not 24 hours, keep up their other pain regimen, the orals or whatever they're giving. Mima's 88 pounds. She's skin and bones. Do you think this fentanyl patch is working well for her?
No, because you said it needed like fat for things to absorb.
I think I told you at clinicals, right?
Yeah, because I was asking about the Suboxone patch.
Yes. Most patches work in fatty tissues, adipose tissue. You put it up against a bone, it's not going to absorb. So our little Mimas or cancer patients who are not nourishing their bodies well and are losing weight at an exuberant weight, patches, because we think of it as like, oh, they can keep it down, we don't have to worry about it, can actually be minimally effective. More you know. Sorry about my little spiel. Like I said, that's my little area of love is some stuff and palliative. And leucocorvin. What y'all remember what that one's for? We give it after what chemo? Methotrexate. Good job. Yes, after. Why do we give it after methotrexate?
It helps protect the healthy cells.
Perfect. Look at y'all. I did teach y'all something. Maybe not a lot, but I taught you something. Perfect. And this, so we use caution as warning signs for cancer, right? Bites is going to be for signs and symptoms of treatment. Treatment to chemo or radiation. Adverse effects to treatment. So, bites is bleeding, infection, tiredness, emesis, and skin changes. All of these are potential expected signs and symptoms of chemo or radiation. We want to assess them as a whole. And how severe are they? Bleeding, infection, tiredness, emesis, and skin changes. Last one, these are colony stimulating. Basically, these are basically specialized proteins that signal the bone marrow to produce certain cells. So we know erythropoietin does the red blood cells, etc. You just may see that. There's nothing. All right. I'll stop right there. We have like hospice care and oncological emergencies to get through, so we start getting into diseases. So let me wait. All right. We are already on slide 32, so I mean we are cooking with Crisco over here. Huh? What?
That's the first time I heard that.
No, seriously, I've never heard
Y'all never
that.
heard that?
Well, I mean,
I've heard cooking with gas.
With grease.
My prior
Crisco
Chris going? I don't know. I've always said that. Anyways, hospice care. I've talked about this a lot with child, so I'm not going to go over. It's a very similar thing. If this is a passion of yours and you ever want to talk to me about hospice, listen, we can have a whole conversation and I'll be more than happy to. Rule of thumb, 2 physicians, not, especially in Georgia. Georgia's a little behind when it comes to nurse practitioners and PAs. You moved. I was very confused for a second. Okay, scroll moment. NPs and PAs cannot have their own practice in Georgia. We're still quite behind. You have to have a co-signing physician. So, 2 physicians, MDs, have to sign off that a patient is what we consider terminal, that they have less than 6 months to live. Is this an exact? No. Have I seen people far outreach the 6 months? Many a times. Sometimes, especially cancer patients that have been going through aggressive, let me make sure I recorded that. Yes, I am, okay. That are going through aggressive chemotherapy and radiation actually start feeling better because we're not pumping them full of toxins and radiation. So they're like, they have cancer. It's terminals everywhere. And yet Paw is walking around the block again. It's not going to last forever, but we sometimes do see this increased quality of life, as well as we've even seen when people who choose not to pursue any treatment, they're 85 years old, said, hey, my personal choice is I've lived a good life. I don't want to go through chemo and radiation. And they live a little bit longer because they aren't putting their body through so much treatment. So there's a lot of ethical, what you have to go with the patient being their own quality. But rule of thumb, 6 months or less to live. Again, that is not always so, because a lot of times patients are and families are dealing with the grief of hearing that. But it's not always. But don't give them false hope either. We oftentimes, other than kind of giving this prognosis, you will notice doctors don't like to give a time limit. Because I'm telling you, then people like to play funnies with you, the patients themselves. I have had a patient, I swear to you, this man did not eat for 3 weeks. We went in there almost every day to his poor son and said, I don't know how much longer your dad has. He's not eating. We might be looking at like less than a week. And 3 weeks later, he did finally pass, but 3 weeks later, he was still there. And another patient I had, actually both of these patients were in this area, in Midway, Hinesville, that area. Another patient I had, I was talking to him, he was up, he used his walker, he got around, we were joking, he's like, you need to come hang out with me. I was like, I'll save you for my last patient. I wasn't actually going to hang out with him, but, being camaraderie kind of thing. 3 days later, he passed. He was talking to me, he was joking. I think he was having a little cup of whiskey. Listen, you're on hospice, do what you want to do. They will defy every odds. So to say you will get that situation if you work in anywhere and you are having a terminal or very sick patient and family says, how much longer do you think I have? Tread carefully with your words. Even if you work in a nursing home, a lot of these are chronic patients, right? You see the patients. So a family walks in, says, how long do you think Mima has? Be very careful with how you answer because they will try to hold you to it. If you say you think Mima has another month and Mima dies a week later, guess who they're now mad at? You. Sometimes it's the reverse. You say they have a week and Mima lives for a month and they were making all these preparations and it didn't happen. So be careful.
Don't a lot of patients get like a burst of energy right before they pass?
Some do. My Dad's best day in the hospital stay was his last day. He was the most cognizant. He didn't have dialysis that day. He, I think, was off the nasal cannula. It's been a long time now. But it was the most cognizant day he had, and he died that night. Told us he was not spending another night freezing.
Isn't it called like terminal lucidity or something?
Something like that, yeah. Like they just kind of, and they know when patients sit there and tell you, I'm dying, I'm not going to be here, I'm leaving, you might want to listen to them, especially if they're a full coat. So, hospice, back on track, sorry. Like I said, this is my jam and butter. Inpatient or outpatient? We have one inpatient, unless something has changed in the last couple of years, around here, which is Hospice of Savannah. And even then, I think that they have changed a little bit of their inpatient. It's not as much. So inpatient hospice. Typically, think of this as like the ER of hospice care. They are not meant to stay there. It is not for them to come in and necessarily pass away there. They may, but this is not for. It's a common misunderstanding, I guess is what I'm trying to say. Some people say, oh, I want Nima on hospice care, and thinking of it as like a nursing home that they get to come stay there. Think of it as they have acute needs. They need IV morphine. The oral's not doing it. They're in 10 out of 10 pain crises, or we've tried rectal compazine for nausea vomiting. They can't keep the sublingual down. They can't keep the pill down, and they are just vomiting profusely. That's what I'm talking about. Like we're treating very acute symptoms, get them stable, and they go back home or wherever they're going to be safe. Now, do patients still die in inpatient? Yes. We have done withdrawal of cares in inpatient. So we brought them from the hospital to hospice house, and then we will pull the vent, the tube, the ET tube. We'll make sure they're comfortable. It allows a lot more family members, kind of thing. But most of hospice cares are going to be outpatient, meaning that they get a visit from a nurse. There's typically a scheduled 1 or 2 week visit. We'll bring in CNAs to help with like a bathing, but they are not there all the time. So it is a lot of education for the caregivers. They're giving the medicine. So again, a lot of you. My favorite was, I remember I switched from a critical care to hospice, and I was like, I'm gonna lose all my skills. And let me tell you, my autonomy jumped tenfold by hospice. Because I didn't have a team of saying, oh, hey, Miss So-and-so, come lay eyes on this patient. Something doesn't look right. I didn't have a second opinion. It was my eyes. I now had to educate all the meds, disease process, etc. So, just don't think it's always. It is very fulfilling. You will work with an interdisciplinary team. Most hospices are going to have social workers, chaplains, as well as they will often have relations with other religions and different things. Rabbis for the Jewish community, etc., etc. To really holistically care for this patient at their end of their life. And again, family caregivers are either going to be your biggest blessing or your biggest curse. They are the ones who have got to take care of the family member, and you may be the one realizing they're not. And that's a whole nother spiel. But yeah, if you want to talk hospice, come talk to me any day. Any questions on hospice? I think I really all said that. So, oncological emergencies. Superior vena cava syndrome. Oftentimes this occurs with lung cancers. Basically, enlarged lymph nodes block circulation in the superior vena cava. This will result in edema of the head, neck, and arms. as well as cause shortness of breath, coughing, chest pain, facial redness, and swollen neck veins. We will also use radiation therapy to try to decrease that tumor that's causing that compression, to allow circulation to resume. So knowing some of our signs and symptoms there, what do you think are going to be some of our nursing indications? Let's talk about start with shortness of breath. What's our number one thing we can do to help someone breathe better?
The head of the bed.
Head of the bed up. Good job. We are going to not want them to have restrictive clothing, right? Probably want to put them in, if they're having a lot of swelling up here, probably like a button up or something like that, or a very stretchy shirt. No turtlenecks that day. As well as avoiding taking blood pressures or venipunctures, blood draws, IVs in their arms. Likely, if they are a chemo patient, dysto we may be considering sports. But we can, as nurses, get quite adventurous where we put IVs. I have seen IVs in feet. So, get quite frisky if you want with that. We're going to try to avoid those. Again, hopefully they have a port, so depending on where the port is and if the doctor approves it, we're definitely trying to avoid any sticks to their arms. Because thinking, where is our superior vena cava? Up, right? So that's why all this swelling is up here. Up. Spinal cord compression. This is where a tumor presses on the spinal cord. What do you think some of our signs and symptoms are going to be if we're pressing on the spinal cord? Huh? Sorry, y'all all talk at once.
Loss of feeling.
Loss of feeling, pain, constipation. What about motor function? Is it going to decrease? So some of our nursing indications are going to be providing a safe environment for them, watching their neurologic status, as well as their neurovascular, their perfusions. Hypercalcemia. Oftentimes this is associated with the release of calcium into the blood due to bone deterioration. So again, hypercalcemia is associated with the release of calcium into the blood due to bone deterioration. We oftentimes will see this with patients who are having metastasis occurring. Often with patients who have breast cancer that has metastasized. Anyone know what we consider hypercalcemia? What's the value?
Above 11.
Above 11. Good job. And tumor lysis syndrome. We talked about this with the peds a little bit. So this is what happens when, so lysis is what? Cell destruction. Perfect. So as these dying cancer cells or destroyed cancer cells flood the bloodstream, they release with it toxins. This is a medical emergency. It kind of has an like a quick onset of 4 hallmark signs and symptoms, signals, whatever you want to call it. The first one is hyperuricemia. Hyperuricemia. This is high what? Uric acid. What did we say was a medication that can help with this?
Allopurinol.
Allopurinol. Perfect. Hyperkalemia. High potassium. Hyperphosphatemia. High phosphates. So 3 highs. I said 4 signals, so 3 highs. High uricemia, high potassium, high phosphate. The 4th hallmark sign and symptom is hypocalcemia, low calcium. These are the 4 hallmark signals of the tumor lysis syndrome. Hyper, hypo. Low calcium. We're going to treat this by trying to treat those. So some of the medication to bring down potassium, bring down the uric acid, bring down the phosphate, give some calcium, as well as IV hydration. If we kind of give that fluid, booster that fluid, the toxins aren't as concentrated. Any questions on anything that I've covered to this so far? Now we get into the diseases. The first one will be familiar. So, if you see, I put chapter 28 because if you have not already realized, there is not one. Everything I've covered up to now has mostly been in chapter 11 for your studying purposes. Chapter 11 is about treating the cancer patient. We want to talk about cancers themselves. So now we're getting into it, and it's all over your book. So I tried to give you the chapters they're in. Well, chapter 28 are blood and lymphatic disorders. Leukemia. Wow. Talked about all of this like weeks ago. Whatever it was. So, patholeukemia. Again, a lot of these are going to be repeat slides because just because it was for kids means it also works for adults. Patho doesn't change. So, patho is immature white blood cells, also called leukoblasts, right? Are overproduced in the bone marrow, lymph tissue or lymph nodes, and the spleen. Etiology, for the most part, is no single cause. And as we already talked about, a lot of our risk factors, I'm not going to go one by one unless there's a very specific one. Like I said, smoking is across the board, just about, as well as if you have a family history or genetic part. So we have different types. So we have 2 acute, 2 chronics. We have acute lymphocytic leukemia, acute myelogenous leukemia, chronic lymphocytic leukemia, and chronic myelogenous leukemia. Excuse me. Y'all remember which one is more common in children? ALL. So we do see AML in typically the acute myelogenous leukemia in people over 60 more often. That's not always, but more often. And it typically does carry a very poor prognosis. However, the most common in adults as a general, is going to be the chronic ones, chronic leukemias, both of them. So chronic lymphocytic leukemia is predominantly affected by the B and T lymphocytes, so your B and T white blood cells.
Can you say that again?
Yes, so your chronic lymphocytic leukemia, the CLL, is most common leukemia in adults and predominantly affects the B and T lymphocytes. So, most common leukemia in adults and predominantly affects the B and T lymphocytes. The chronic myelogenous leukemia, its specialty, etiology, cause is it has an abnormality in a chromosome called the Philadelphia chromosome. So in the chronic, the CML, chronic myelogenous leukemia, the etiology is going to be genetic because there is an alteration in the Philadelphia chromosome. It occurs more often in older adults. So CLL affects the what lymphocytes? B and T. The CML is affected by what? Philadelphia chromosome. Good job. So, leukemias across the board typically have fatigue. I know, who would have ever guessed? With decreased immune system, that bone marrow is not producing like it's supposed to. So we will have the bruising, the petechiae. Sometimes the patients may complain of chest pain. So if everything is low, we have low, even though we have an excessive amount of immature white blood cells, they're not effective. So everything is low. We have low white blood cells, they're at a risk for what? Infection. If they have low platelets, they're at a risk for bleeding. And if they have low red blood cells, we have anemia, right? What also goes with anemia? With red blood cells, hemoglobin specifically? Oxygen. Iron is one of the things that helps carry it with the hemoglobin. Oxygenation. So we may start having some of that shortness of breath. They may even have chest pain or perfusion problems. So if we start noticing those, what do you think we're going to give them? If they start having severe signs of anemia, poor oxygenation, excessive fatigue, what do we treat anemia with? Packed red blood cells. What are some signs and symptoms of DIC? Let's start with DIC. What are we most risk for DIC? They are doing what? Excessive bleeding. So what are some signs and symptoms we may see besides seeing blood that maybe internal bleeding is occurring? Swelling, fluid, petechiae, possibly some nausea, vomiting, right? Especially if it's pulling in your stomach. What about back pain? Back pain?
That is everything just being coming out all at once.
Kind of, yeah. Like it's like there's just can't clock.
Yeah,
Can't
death
clock.
is coming, so.
So some of our big signs and symptoms is we're seeing petechiae. Like, so if you're not seeing excessive bleeding, if you are seeing blood rushing out of something, we know what's going on. We know something's happening. Some hemorrhage, bleeding problem. But if the patient, you're noticing bruising in random places or excessive bruising, petechiae, some nausea, they start saying, man, their back's severely hurting, turn them over. They may have a pool down there. They have giant blood, a giant bruise. Because if they're laying on their back and they're bleeding out internally, where's all the blood pooling? In the back. Our diagnosis, CBC, bone marrow aspiration. We talked about lumbar punctures as well as MRIs. Treatment, same as before, and pretty much same for all of them, chemo, radiation, as well as, what do we call the precautions we put them on? Good job. Any questions on leukemia? I know I went fast, this is a repeat disease, and like I said, the patho, the diseases, it's still the same. Next one is a new one, multiple myeloma. So, these are going to be cancerous cells in the plasma. So, cancerous plasma cells reproduce uncontrollably. And by producing these cancerous plasma cells, they produce useless antibodies and ultimately substances that cause osteoclasts, which are bone cells that are meant to break down the bone. Their bones are constantly regenerating. Not saying they're going to regrow, but they're constantly regenerating. You have osteoblasts, you have osteoclasts, etc. To speed up bone destruction. So the excessive plasma cancerous cells produce substances and antibodies that cause the osteoclast to speed up destruction. If the bones are being destroyed, what is as a whole, what is going to be our worry? The integrity of the skeletal, the bones, right? Bones are going to be weak. We're at higher risk for fractures. Multiple myeloma usually affects these bones of the skull, pelvis, ribs, and vertebrae. Multiple myeloma usually affects bones of the skull, pelvis, ribs, and vertebrae. Cause unknown, like a lot of cancers. So some of our signs and symptoms are going to be bone pain that gets worse with movement. We may have pathological fractures. So these are fractures that occur when there's no trauma. They just fracture because they're weak. So it's not, they didn't get in a car accident. They weren't playing football. Pathological fractures just occur. It may cause some spinal cord compression, which then we know can cause that nerve pain, loss of feeling. So the patients are at increased risk for wounds or even burns because they can't feel temperatures. Excessive cases, they start losing their neurologic functions like their bowels and bladder. If the spinal cord compression occurs, this is an emergency treatment, because if not, what happens when we stop blood flow? Tissue does what? Dies. Can we regenerate tissue normally once it dies? No. So if we do not fix the spinal cord compression, that patient may be paralyzed. We may also see hypercalcemia, because think the bones are breaking down and destroying, releasing calcium into the bloodstream. So, x-rays. And I have a picture here in a second, you'll see. The x-ray shows Swiss cheese-like bones. So what does that mean? You can like see holes in the bones. We're going to do some blood tests like CBC, calcium levels, because we know hypercalcemia is a positive sign and symptom, as well as kidney function. We may see positive M-type globulins, also known as Vinci-Jones proteins, in the urine or blood. The MRI, what do you think is going to be, is what do we call the bone disease where they have really fragile bones?
Osteoporosis.
So the MRI is likely to show osteoporosis of the bones. As well as we may do a bone marrow biopsy. Where do we normally do the bone marrow biopsy? Iliac crest. So some of our treatment is going to be corticosteroids with chemotherapy. But to help with the osteoporosis, we're also going to be giving them possibly calcium and biphosphonates. So to help decrease the risk of those bones continuing to break down, we're going to give them serum calcium and biphosphonate. This would be a patient that is could be possibly treated with the stem cell transplantation. Our nursing considerations, first is going to be safe environment, safe from any fault. They're going to be a high fall risk. Again, these patients have very brittle bones, so very gentle care. As well as we're going to try to educate them that our goal is to keep their calcium below 10 and encourage lots of fluids. The fluids are to help protect the kidneys. Fluids will dilute calcium and help flush the kidneys to help reduce the risk of kidney stones or other adverse kidney effects.
You said you want to give them serum calcium, right? How do you
Yes,
keep
or-
that in their bones rather than their blood?
I'm trying to think of how I want to say it. So how our body deposits nutrients the whole way through, right? Like, so we carry oxygen through our bloodstream, but we then do what with oxygen? We drop it off to organs. Same kind of thing. If we're giving them serum calcium, we're giving them calcium, or even like think IV potassium, right? It still goes into kidneys, urine, etc., all that kind of stuff, right? Potassium does. Same thing. So the blood is the transport system, but it does drop it off at places. So it'll drop it off through the bones. Does that make sense?
Yeah.
So same thing. And just simply why we have hypercalcemia as a calcemia as a side effect, because it's breaking down the bones and then the blood system picks it up, and now we have high serum calcium. Same thing for disorder. That make sense?
More or less.
So, like any medication, it doesn't all just stay in the bloodstream, right? It gets dropped off to wherever you're hoping that it's treating, right? So same thing, it's getting dropped off wherever it needs to be metabolized for your body to properly use it.
Okay.
Bones, heart, muscles, wherever the calcium is needed at that time. So here you can see a normal bone versus the Swiss cheese kind of looking. Let's see. Oh, gnarly little, yeah. Extra. Oh, thank you. Any questions on multiple myeloma? The next one is a repeat, so we are going to go kind of quickly. Lymphoma. We have the two, well, we have multiple types, but what are the two types we talked about? Hodgkin's and non-Hodgkin. Perfect. What is our zebra for Hodgkin's? They have what? Reed-Sternberg cells. Didn't change from children to adults. Same thing. Non-Hodgkin's. Do they have Reed-Sternberg cells? No. Perfect. Lymphoma. What organs does it mostly affect?
Lymphatic system.
The lymphatic system, which includes your lymph nodes, spleen, tonsils, bone marrow, etiology is still relatively unknown. There is a relation to those that have had the Epstein-Barr virus or mono. Y'all have seen that picture before. That's just the Reed-Sternberg cell. If we see Reed-Sternberg cells, we think what? Hodgkin's lymphoma. So our signs and symptoms, we're going to have swollen what? Lymph nodes, typically upper, right? In our neck, our is cervical and supracervical clavicular. We may start seeing our weight loss, night sweats. We know those are some of our big ones, right? Fever, weight loss, night sweats. Some of our later signs can be swelling of the airway, of the face and neck. And if we have swelling of the face and neck, we're thinking swelling of our airway. So what would be the respiratory sound we hear if it's swollen? Strider. Good job. So as that cancer, those tumors, those lymph nodes grow, it can cause compression. And we may be looking at airway obstruction. Is that an emergency? Blah, blah. Drinking alcoholic beverages can trigger the intense pain of the cancer site. Our diagnostic tests are going to be very similar to all the other ones, CBCs. We may have an ESR, the sedimentation rate. Lumbar puncture, bone marrow, gallium scan. Let's see if we remember this one. Staging. Stage 1, where is it? Just in your lymph node, right? Just in that one area of the lymph node. Stage 2, it's spread. But what's the defining characteristic of stage 2 versus stage 3? All are still in the lymph nodes. It's either one or the other. Stage 2 is either above the diaphragm or below the diaphragm, depending on where it originated, right? But it has not crossed the diaphragm. it's either gonna be all upper, which is the more likely, because we said our cervical and supraclavicular are more likely to be where the lymphoma occurs, or below. Stage 3 is still our lymph nodes, but it has done what? Past the diaphragm. We see it above and below. So remember, and or. And or. And stage 4, it has spread to
Other organs.
other organs. Okay. I get some proud of y'all. All right, treatment. We have covered this already. Chemo, radiation. If we have a vaccine, that's going to help keep them because their immune system keep them safer from getting some of our viruses. You could also probably add on there like COVID and flu. Again, always check with doctors, especially for like flu, because that can be a live vaccine. We do have inactive vaccines for flu. They're just not quite as effective. So what the doctor does clear for them, but their immune system is weak. So anything we can give them that will, when they are healthier in a higher immune state, the better we can to help them not get a virus that can take them down significantly. This is just a comparison. You can see non-Hodgkin's is more common. For prognosis, the Hodgkin's is those Reed-Sternberg cells. It does occur more often in younger populations. Better prognosis, the alcohol may induce the pain. Alrighty, let's see. I'm gonna give y'all like a 10-minute break because like this is just a good breaking point. I know y'all had one about 45 minutes ago. It's right at 10 o'clock, but we're getting into another chapter, so it's just a good break. So I'm gonna give y'all 10 minutes. So be back at 10:10. If you're all here beforehand, I'll start even. But you have until at least 10. All right. This is chapter 30. I'm going to talk about cancer of the larynx. So, I told you in the beginning, kind of a lecture. A lot of this is based off of the where is the cancer located. So, what is your larynx? We call it the what? Voice box. So, what do you think are going to be some of our big issues with this one? Hoarseness, concerns with breathing and swallowing, and communication, right? So our patho, this develops in the squamous cells of the mucosal epithelium. It oftentimes spreads to the lungs, liver, and lymph nodes. It is more common in men than females. It is related to alcohol and tobacco use, chronic overuse of the voice, exposure to HPV, poor diet, and exposure to chemicals. As y'all just said, one of our big signs and symptoms is hoarseness, and this is going to be hoarseness that doesn't go away. It's not related with a sore throat, virus, bacteria, strep, something like that. It's going to be a chronic kind of hoarseness. They may have throat or ear pain, as well as that difficulty swallowing. as well as difficulty communicating as it progresses. I don't know if it was this one, but it was similar. I had a patient had a tumor, and I'm not lying, when the growth was out here. I don't know if Savannah can see me. Like, here's me. I'm trying to make sure I can see. Like, it was out to, like, not quite this far, but it was out there. And he was an interesting soul. That's all I'm gonna say about him. He was an interesting soul. But difficulties communicating. He couldn't talk. He had a journal with common sayings he would ask for and different things. He had to write all of his communication at that time. So our diagnosis. So one of the diagnoses that I didn't include in our common diagnoses is scopes. We use a scope to look at internally, right? It's a scope that inserts the body. We have endoscopes, they go down. Colonoscope goes into the colon, goes up the rectum. As well as oftentimes with these scopes is how we can sometimes be able to obtain a biopsy. To obtain part of the tissue to send off for biopsy treatment. As well as a CT and MRI. If it is diagnosed early, it is often treated with just radiation, but as it progresses, we can combine it with chemotherapy or surgery. There we go. Surgery can be done at any stage. It can be done even early, but at any stage it can be done, which will include a partial or complete laryngectomy. So, partially or completely removing the voice box, the larynx. That complete would be our last resort. We want to preserve that as much as possible for both swallowing and speech functions, quality of life, right? If it is spread past the larynx, we may have to do what we call a radical neck dissection, which will not only remove the larynx, but also remove adjacent muscles, lymph nodes, and tissues.
What was it called?
Radical neck dissection. Radical neck dissection. This will be a fairly painful procedure. When we talk about the muscles, think of how much you use a lot of these muscles without even thinking about it. If they have a partial laryngectomy, they will have a permanently hoarse voice. They will never get their full voice back. But if they have a total laryngectomy, they're going to have a permanent tracheostomy. They will always be trach dependent, not necessarily to breathe, like on a ventilator, but they won't always be on a ventilator necessarily, but they will always have that trach piece in place. Hoarseness. So their voice, however they know it, will never be the same. They'll have permanent hoarseness, but they'll still be able to learn how to re-speak. Versus if they have a complete laryngectomy, they're going to ultimately have the tracheostomy, the trach. And we'll have to use that to speak. This is in your book. Y'all know I just like my tables and stuff, so I try to put it there for you. This is a very blanket, I'm not reading this directly for you. Signs, symptoms, diagnostic test, much what we just talked about, treatments, nursing diagnosis, and a pretty little one slide, easy visual. Again, it's also in your book, but I just put this here for you. So, how are we going to help them potentially communicate? We have devices for aid speech. There are a couple. I like to throw out there when I'm not super proficient in something. I don't work with speech therapy. Anytime I'm taking care of someone, they've had it typically for a while, or they had just gotten their trach and talking was not our priority at that point. They were normally still on the ventilator with it. So when I tell you that we can find the answers together, we can do that. But to say, when I tell y'all I'm not proficient in something, it's one of those. So first off, who do you think we're going to consult? If this has happened, who's one of the first people we're going to consult?
Speech therapist.
Speech therapy. They're going to come in and do a lot of stuff for us. And be far better at it than me. They're going to assess their swallowing as well as their ability to communicate depending on partial or total laryngectomy. So the Ultra Voice is an electronic device that's typically placed up in an either denture or like a retainer. So you can see it's up there on the top palate of the mouth. And essentially it is a small little microphone. It is, it helps them project their voice. The Blom-Singer voice prosthesis is a surgically implanted voice prosthesis, in which case they surgically put a valve between the trachea and esophagus. Anyone remember the old like scary commercials for the no smoking devices where they had somebody who talked like that's what that is. They had to put a hand over there to help the vibrations, the air not escape to project their voice. That's a Blom-Singer device, also called a tracheoesophageal puncture. So trach, Trach. EO, esophageal, ESOPHAGEAL, tracheoesophageal puncture device. Let's see. You sneeze? No. Okay, never mind. Hearing things. Huh?
Oh, is it yawning? Sorry.
It sounded like a sneeze. Any questions on that? I apologize for not being more advanced. I just don't have not a lot of my patients have. Chapter 31 is going to be lung cancer. We have a couple different types of lung cancer. Most of what I talk about is kind of like a whole, but we will talk about them a little bit individually. So typically this starts in the lining of the bronchi. It can also produce ectopic hormones. If y'all remember from back in those statistics, this is a very common cancer, as well as the prognosis is not very well. It has a poorer prognosis than most. One of the biggest ones you'll see is small cell lung cancer, also abbreviated SCLC. It develops in the small cells of the lungs, where it develops. That's the patho of it. Again, our risk factors are very similar to everything. So SCLC. This occurs in about 10 to 15% of the lung cancers. So people diagnosed with lung cancer, about 10 to 15% will have SCLC. Very poor prognosis. Usually survival is less than a year. Very, very poor prognosis. Most commonly caused by smoking. We have our large cell carcinomas. Occur in the large cells. One thing about the small cell, it normally occurs in the bronchi versus large cell occurs anywhere in the lungs. So small cells are more likely to occur in the lining of the bronchi. Large cell anywhere in the lungs. Large cell also metastasizes quickly. Adenocarcinoma does occur more often in women. It is slower growing. But because of that, it is often not diagnosed until it has metastasized. Adenocarcinoma occurs more often in women. It occurs more often in the peripheral lung fields. So think kind of your peripherals, the sides. Slower growing. But due to that, it is not often diagnosed until it has metastasized. Adenocarcinoma has less of a link to smoking. Smoking, not saying smoking cannot still be the cause, but there is less of a link, more of like a genetic link.
What part of the lung?
Peripheral lining, so kind of think the sides. Squamous cell carcinoma. It usually originates in the lining of the bronchi as well. It does not typically metastasize until very late in the disease process, meaning it has a better prognosis than the small cell. So squamous cell also occurs often in the lining of the bronchi, but does not metastasize till later, meaning it has a better prognosis than some other lung cancers, such as the small cell lung cancer. The squamous cell lining of the bronchi as well. So if I were to say lining of the bronchi or near the bronchi, you think of two main ones, right? Small cell and squamous, so your S's. Which one has the poor prognosis? Small cell. Etiology, smoking. Here's a fun fact for you, in case any of you judging you. I promise I'm not. I'm giving you the medical facts. If you smoke or you live with a smoker, living with a smoker increases a non-smoker's chance of lung cancer by 20 to 30%. We are starting to find out secondhand smoke is just as bad, in some cases worse for you. than actually being the smoker yourself. And not just even lung cancer, it can also increases your chance of all the others, such as breast cancer, brain cancer, etc. I say this to also say, this is the generation of vapes. We don't know the full, I'm just going to say this. Anything you inhale in your lungs, dangerous. I don't care if it's natural, doesn't have nicotine. And you're putting a chemical, whether natural or not, into your system, into your lungs. Just think about that. We have a lot of high schoolers. That's the cool thing to do now, right? Think about it. We already know it's called what we call popcorn lung, but we don't know the true ramifications because this is the generation that started it, right? Relatively. What do we think? Who knows what we're going to see in 20, 30 years? So, just take that as you will. Signs and symptoms are pretty typical lung signs and symptoms. We're going to have a cough with sputum production. We may have hemoptysis. What is that? Blood in the sputum, right? They're coughing up blood. Hemoptysis. Oftentimes, the sputum is going to be very thick, maybe purulent and colored. These patients are going to have back-to-back repeat respiratory infections. Complications. Some of them we've already covered, like superior vena cava, pleural effusion. What is a pleural effusion? That is when what becomes what? Fluid becomes trapped where?
In the blue space.
I think y'all said. What y'all say?
Floral space.
Pleural space. Pleural effusion. Fluid becomes trapped in the pleural space. What is the pleural space exactly?
Between the lungs
It's the-
and the thorax cavity.
Yeah, it's the sac covering the lungs, right? Is this an emergency?
Yes.
Are they going to have trouble breathing? The ectopic hormone production. So part of the patho is it produces, it can produce these ectopic hormones. So ectopic hormones can mimic the body's own hormones. So some of our natural hormones are going to then be elevated, such as we can have the like ectopic production of antidiuretic hormone. What is this going to lead to? If we have antidiuretic hormone, it's going to lead to what? Fluid retention. Good job. If we have ectopic hormone production of ACTH, cortisol, going to cause what syndrome? Cushing's. It can mimic ectopic hormone production of the parathyroid-like hormone. Can elevate which electrolyte? Calcium. Oh, you're so smart. I love y'all. Like, it's just such a blessing. Yay, I'm proud of y'all. I didn't teach y'all that. That was all whoever did endocrine for y'all. But I'm still really proud. Y'all are saying things. Listen, I don't know if I could have said that when I was a nurse. A nursing student, I should say. Let me do that. Nursing student. I probably looked at my instructors like I had 5 heads. We also may have atelectasis in pneumonia. What is I know y'all know what pneumonia is. What is atelectasis?
Collapse.
Lung collapse. Good job. Or can't ventilate properly, can't inflate, deflate properly. And then as well as metastasis, which we know means it's spread. Our diagnoses always go least invasive to most. We're always going to start with the chest x-ray. Patient comes in with a cough that's not getting better. And they're coughing, coughing, coughing. Start with a chest x-ray. Then continues to go on all the way up to a biopsy. If possible, we may do surgical removal of the tumor. Whether this is going to be just a lobectomy, one part of a lobe, all the way up to we can remove a whole lung. One. Chemo, radiation. Here is a table also from your book about stages of lung cancer. You can read that but for the general consensus, 1 is where we typically don't spread, we haven't spread, and 4 being we've spread. Yes, Autumn.
It says superior vena cava on the last slide, but not anything about it.
I already covered that in the oncological
Sorry.
emergencies. You're good. So that's why I didn't cover it again, because I don't have anything extra to say about that. But yes, that is a potential complication.
Okay.
Y'all can read that. Again, it's also in your book. Here's just lung cancer on scan. You can see the tumor. As well as, I can't read it there. You can see all the different. Where's my mouth? Here is a wedge. These are all surgical interventions. A wedge, we just removed a wedge versus segment to a whole lobe to an entire lung. Which one do you think we're going to try first if we can? Wedge. Always least invasive to most invasive. Yay! 33. Any questions on larynx or lung? Oral cancer. It's found in the mouth or the throat. This is oftentimes related to any form of tobacco. So chewing tobacco just because you're not smoking it, also still dangerous. Or also excessive alcohol use. This is going to cause sores in the oral cavity that are going to take 2 or more weeks to heal. As it progresses, or if it's more in the throat, it's going to cause difficulty chewing and swallowing. We diagnose it with a biopsy. And we typically treat this with surgery, either being a radical or modified neck dissection. Will be on this slide. So the radical neck dissection. I also mentioned this may be a treatment for which cancer? Larynx. So the radical or modified actually being the preferred neck dissection, is because this has this cancer has metastasized to the cervical lymph nodes, so the lymph nodes in the neck. The traditional way, traditional way is going to be like hands-on surgeon cutting through, versus the modified is going to be a robotic arm. You have found that a lot of robotic arms are very specific because you have to line them up perfectly, etc. But ultimately in these neck dissections, What are we removing? I already said it earlier. We're removing the tumor, we're removing the lymph nodes, and we're removing what? Possibly tonsils, muscles. This patient will have those drains to help keep fluid from accumulating, as well as they are likely and most likely going to have a tracheostomy for airway protection to keep that airway open as they're healing.
So I have a question. So as they get that trait,
Would it be like TPN, like from eating at that moment?
Typically, if we know someone's going to get a trach, they're also going to get a peg tube. Now, I'm not going to say every single case, but oftentimes TPN is so specific, and normally for a short term, peg tube can be nourishment for a longer term. And these are patients that are very much genuine, appropriate candidates for a peg tube. So I'm gonna let my hospital show again for a second. Oftentimes, like Alzheimer's, Meemaw has stopped eating, people will say, let's get them a peg tube. It actually can increase their chances of aspirating and dying sooner than the nutrition. But people with cancer or strokes where we're rehabilitating and getting them back, peg tubes are fantastic options. I'm never going to take away someone's willing for quality of life and stuff, and that's what we choose. We just have to do our best education. But this patient will likely get a peg tube as they are working on healing the trach and everything up here, because this is all going to be traumatic and painful, right? Until they come through, they'll likely get a peg tube for nutrition. Does that answer?
Yes.
TPN is normally very short term, hospitalized. Like, there are cases out there, gastroparesis and different things, where we do the TPN because the stomach is not absorbing appropriately. And you teach them how to do it at home. You can watch TikToks on, I've come across a couple people who are well versed in all that. But oftentimes, peg tube is a little bit less risk for infection. It's not going right into the bloodstream, as well as a lot more education, like ability to teach. As well as TPN, also insurance. TPN is very expensive. Very expensive. Any questions on oral cancer? That one's a fairly simple one. Throat and mouth. It presents as sores. We oftentimes treat it by removing the tumor with a surgery. Esophageal cancer. It starts in the esophagus. Also highly related to tobacco and alcohol use, as well as obesity, human papillomavirus, or even Barrett's esophagus. Some of our starting signs and symptoms is going to be dysphagia. What is dysphagia? The difficulty swallowing. So with that, we may have some weight loss because they can't consume appropriate nutrition. They may have kind of like that indigestion feeling or a fullness, pain in their chest after eating, because think that tumor is blocking the esophagus. So it may not be able to go all the way down, or when it is, there's still that pressure. It gets caught. As the cancer progresses, we can't even get into a complete obstruction of the esophagus, which can lead to perforation or a fistula developing, which then increases our risk for aspiration. So increases the risk for fluid or food to go into the lungs. Our diagnoses are going to be an EGD, which is the scope that goes down the camera, that goes down to look in a biopsy. Esophageal manometry. This is going to be a meter for the esophagus. Basically, it is a device that is going to assess the esophagus's motility. The ability for it to contract, dilate, and contract, and food to move up and down. Esophagus motility is what the esophageal manometry does. Some of our treatment, same as everything, chemoradiation. So some of our surgeries, oftentimes it's going to be surgery as our most common treatment. Remove the tumor, possibly the section that is the tumor is affecting. And we'll oftentimes, it can do one or the other, but oftentimes most of these things are combination therapy. So surgery with chemo and radiation. So the different types, esophagectomy. What do you think that is? Removal of esophagus. Good job. The esophagogastrostomy. What do you think this does? Huh? Just, yeah, it's just, yes.
Resectioning.
It is resection. So basically it helps connect the esophagus to the remaining part of a stomach. So they cut out a part of it, so it's connecting the esophagus to the stomach. And the esophagogastrostomy. A lot of words. This is going to be where they take a part of the colon, so the third one up there, for those that can't follow my speaking abilities. The third one up there. Part of the colon will be resected and put in place to act as the esophagus. So they'll remove part of the colon and put it as the esophagus. If they cannot operate on the tumor at all, they may be trying to do things such as esophageal dilation or stent placements to widen the esophagus. So esophageal cancer, a lot of these are GI cancers, right? But when we're talking about treating them, nursing considerations, what do you always think of first? What is always going to be our priority? Airway. Confidence. We got this. Confidence. ABCs. How many times have we heard that one? Airway, breathing, circulation. Do you think having surgery that affects your esophagus can potentially affect your breathing? We talked about it could be obstruction, right? So, it can cause regurgitation and aspiration. So always with any of these surgeries, any of these cancers, number one priority, always, the airway, their breathing, or their circulation is damaged. That's always the priority. As well as think of Maslow's priority of needs. Is my ability to tell Mima, it's okay, Mima, we'll get you medicine for your pain, as important as Mima? That's not safe. Which one's priority? Pain or safety?
Safety.
Safety. What about pain or Mima's ability to nourish her body? Which one's a priority?
Nourish your body.
Nourish the body. What about Mima's not eating or Mima is having stridor? Gotta keep you on my toes. Any questions? Brachytherapy is related to the radiation that I talked to in the beginning, the type of radiation we would use if it's an inoperable.
Can you repeat that?
Yes, so the brachytherapy is in relation to the radiation that I talked to in the beginning, or the different types of radiation that's for an inoperable tumor.
Thank you.
Gastric, or you may see a stomach cancer. This is going to be when lesions develop in the stomach. Men are at more risk than females. And if it is not found before it metastasizes, we have a very poor prognosis. So if it has metastasized, the prognosis becomes very poor. Some of our potential causes is H. pylori bacteria. Pernicious anemia, that's a lack of what? Vitamin?
B12.
B12. Obesity, smoking, increased salt intake, as well as smoked food. I'm with the best of them. I love a good barbecue. But if you're eating it every day, you may be increasing your chances of gastric cancer. If it's made well. Good. Not saying don't have it, just be aware if you eat a lot. Or if your patients say, yeah, or they work at a barbecue place, kind of thing. So some of the signs and symptoms. Oftentimes these don't appear until later in the disease, making it harder to detect early. So some of our later signs are going to be weight loss, ulcer-like pain when they eat, nausea, dysphagia, the difficulty swallowing, or melena. What's melena? Blood in the stools. Normally the dark blood in the stools. We're going to diagnose this ultimately with an endoscope and a biopsy. I'm not saying you can't do an MRI and also see these things, but the ultimate diagnosis is going to be through a scope where they get a biopsy. Treatment, gastrectomy, removing part or complete stomach, chemo and radiation, as well as the Billiroth surgery.
What is it, surgery?
You know, I thought I had that written down and I don't. So after break, I will tell you all about that one. I might have it on another note, another slide. Bless you. So I will come back to Bill Ross surgery. I'll put a pin in that part. I will come back to it, I promise. You have your, again, I like tables. My brain processes it this way, so I just put it up there for y'all. But yeah. I really thought I had it written down. I must have written it on a different. All right. Pause for time. Not the door locked now. Yep. 11:10. Did I say 11:15?
You said 11:13 or
Said
something.
10.
I said 11:10.
You said 15 minutes and it was
I
10
told
minutes and 5.
yeah.
Yeah,
I told the one
that it was
15.
Oops. Who is it?
She's got it.
Huh?
She's got it later now.
I told y'all knew the new rules. I'm done with the game. So, Billy Roth 1 surgery, also called a gastroduodenoscopy. This is when we remove this is still gastric cancer. This is where we remove the lower part of the stomach and connect it to the small intestine, which is also called the duodenum. You remove the lower part of the stomach and connect it straight to the small intestine. The small intestine is also called the duodenum. Duodenum. However you want to say it. Why we like it is this does help food keep on the same path as like a normal process down esophagus, kind of through some of the stomach into the small intestine, so we can still metabolize our nutrients, proteins, etc. However, part of our cons is that it can increase the chances of like reflux and inflammation. That's the Billy Roth surgery. So our last of our GIs. Any questions? Colorectal cancer. This is where cancer originates in the epithelial lining of the colon and rectum and can occur colon and rectum and can occur anywhere in the large intestine. Etiology is the typically can occur after the gallbladder has been removed. If they eat a lot of dietary carcinogens, like lack of fiber, smoking, smoked foods, highly treated, processed, chemically treated foods. All of those can increase our risk for colorectal cancer. What we start seeing is signs and symptoms of changes in the bowel habits. Most likely it's going to start with like more constipation, because think as that tumor is growing, we're not going to be able to vacate as easily. Our peristalsis is not going to be able to squeeze as efficiently. We may see blood or mucus in the stool. The abdominal or rectal pain, abdominal pain is not going to be seen as often if it's in the lower half, like in the rectum area. The higher up in the colon is going to cause more abdominal pain. As you move through the rest of the tract, more towards the rectum, you're not going to have the abdominal pain, but you will have the rectum pain. Kind of think of where the tumor specifically is located. Upper colon, more likely abdominal pain. Lower colon to the rectum, rectal pain. You may have some nausea and vomiting, possibly. And we may have some Anorexia. What is that? What do we normally associate that with? What does that kind of look like? Oftentimes these patients appear what? Very frail, kind of emaciated. They're very weak. They will have the inverted abdomen sometimes. So instead of a distended abdomen, if they're cachexic, they are very, very thin. That's going to be in the later stages. Diagnostic test. Basically a scope with a biopsy. Colonoscopy is going to be the lower half. This is going to be a little bit upper. And from there we'll take a biopsy. We'll take a tissue sample to therefore process. We may do CT scans. If they're complaining of more like rectal pain, we may do a rectal exam. Meaning they put the glove and looped up finger and feel in the rectum. We may feel a polyp. We may see blood in the stool if we do a stool sample. Do y'all know what we call that? Remember what we call that test? The occult stool studies, fecal occult stool studies. And sometimes that can be done in the hospital or practice, as well as we can send them home with kits for the fecal occult studies. We may do a double barium enema for blood flow. And then the carcinoembryonic antigen, also abbreviated CEA. This is a blood test that is used to assess the response to treatment of a GI cancer. This antigen is present when the epithelial cells rapidly divide and can show that cancer is present. So CEA, the carcinoembryonic antigen, is a blood test that is used to assess the response to treatment of GI cancer. CEA is present when epithelial cells rapidly divide and can tell us if cancer is present. Treatment. Surgical removal if possible. We may put a stent in for obstruction. Not always, but we oftentimes will end up seeing an ostomy. So what is a ostomy? An opening, right? It allows what to pass through?
I mean, it depends, but usually urine or feces.
Urine or feces. So in this case, we're probably talking about feces. So we're gonna want to make sure we do some education on if they did get an ostomy treatment. Keeping the area clean as best as possible. Should it be beefy and red? Fairly excessively red though? You want it more like pink to red. What about dusky colored?
No.
Gray, blue. How often do y'all think we want to tell, like, about what time when the bag is full? Like, do we want them to change it when it's just a little bit, when it's about half full, or when it's like full? Half full, good job. How often should they change it? This is kind of a good range, so.
hours.
Nope, too frequent.
I mean, it
3
depends.
days.
3 days to 3 to 14 days, depending on how they're reacting to it, the kind of stool they're having, how the stoma looks, etc. But on average, we want them to change their bag, their whole system, every 3 to 14 days.
Oh, you mean.
How about
changing
not
the
the
empty-
bag?
Sorry,
Okay,
yeah, sorry,
yeah.
changing the bag.
I
I
was
spoke wrong. Emptying it, yes, you're gonna empty it when it's about half full is what we wanna do. We wanna change the system, the bag, every 3 to 14 days. Y'all clear on that? 'Cause I might have misspoke. We want to, do we want the tape? We want it tight and sealed, or is it okay if it's got some ridges and it's loose? Tight and sealed. What if the patient says that they're concerned about the smell?
Put in there.
You can put a little bit of deodorant, spray a little bit of deodorant after it's been cleaned and changed to help with the smell or emptied. We talked about the coloring of it. We talked about stents, especially if there's an obstruction or blockage. Talk about surgery, can you read to this? We can do monoclonal antibodies. I gave you a couple up there just so y'all can see if you see those names. They are body image. Is this gonna potentially affect somebody's body image? Yes. So we want to make sure we're cautious of that. We're educating on that. I will say that is one of those beautiful things that has been coming of social media is you see a lot more representation. And so you will see people putting on social media how they care for their ostomies and things to be both educational within its reason, as well as just showing people it is out there. And if we think we typically will start colorectal screening at age 45. Ideally, this is a colonoscopy. This is coming from like the FNP side of me. When people refuse, we can send them home with those stool kits for the fecal blood to see if there's blood in their stool. And if they're not, we kind of say, hey, you're good for a year. But the best is always going to be a colonoscopy, in which case it's ideally done starting at age 45 every 10 years. If they are concerned, they may bring you back every 5. So just be aware of that, especially if you end up working in a doctor's office or something like that. As well as you may be talking to someone where Paw got diagnosed with colorectal and now his son is buried, so you can educate them in those ways. Any questions on colorectal? Cancer of the liver. Oftentimes, this is not, I'm not going to say always or never, but oftentimes this is not the place of origin. This is a high place of metastasis. So cancer has spread to the liver. Some of our big cancers that do spread to the liver are going to be your esophagus, lung cancers, breast cancers, stomach cancers, colon cancer, pancreas cancer, kidney and bladder cancer, and skin cancer. So just about all of them. Huh? Yeah, just about everything. The only one we don't really talk about that spreads there is like blood and the blood cancers and the brain cancer. Pretty much everything else. Some increased risk for this is if they are hepatitis, on the viral. Nutritional deficiencies, as well as heavy alcohol. We know alcohol heavily affects the liver, and smoking. Some of our big signs and symptoms. Encephalopathy, what is that? Inflammation of the brain. So what typically is causing the encephalopathy if we're thinking is the liver? What's causing that inflammation? Possibly ammonia, some toxins, right? Your liver's not processing like it's supposed to because of this tumor. So now we're having these toxins build up, causing that encephalopathy. What are going to be some signs and symptoms of this encephalopathy? Confusion is a big one. Sometimes changes in level of consciousness, right? We may have some abnormal bleeding. Jaundice. Jaundice is a pretty clear sign that something's going on with your liver, right? And as well as ascites. What is ascites? Excessive fluid buildup, typically in the stomach. How can we sometimes treat ascites? Thoracentesis? Where's the thoracentesis?
Abdominal synthesis.
So what do we call that?
Paracentesis.
Paracentesis. Good job. Y'all might have said it in Savannah too. I think I heard y'all say it. Paracentesis, so that may be part of our treatment for symptoms. Ultrasound, again, probably looking, especially if they come in with that excessively distended belly. We're going to also see these elevated liver enzymes, including some very specific ones, ALP and the alpha fetoprotein. We may do a needle biopsy to stage it. And real quick, I'm just going to quiz you really, just a little fun little GI liver part. Super quick. If patients have liver failure, something's going on in the liver, and they have an elevated AST, what are the likely causes? Alcohol, smoking, Tylenol. So just a fun little blurb. AST, S stands for substance. Something you are ingesting, you're taking in, that's causing the liver problems. The ALTs are more associated with like life problems, so genetic concerns, different things like that. So you may see more likely ALT with like liver cancer because it's not necessarily a substance they're intaking that's causing the liver failure. They're both likely to be elevated, but you see AST, you're more likely thinking it, and I'm not going to say always, never say always, but you're more likely to think of a substance they're ingesting. Treatment is going to be surgery if possible. This one does have a very specific chemotherapy that they like for it, so I put that up there. Overall survival rate for liver cancer is low. So remember, this is normally a point of reason from metastasize, meaning that whatever the origin cancer is, it has spread significantly. Cancer of the pancreas. This occurs in the exocrine part of the pancreas, usually called ductal adenocarcinomas. So it's oftentimes, when we talk about the exocrine parts of the pancreas, it's in the head, or the body of the pancreas. and it can spread very rapidly to some of its nearby organs, such as the stomach, gallbladder, or even the colon. However, it can also still spread to the lymphatic and vascular systems to then go to distant organs. But it is very easily spread to nearby organs. Etiology: increased risk when you are smoking or have dietary factors, or if a patient has chronic pancreatitis. Some of the dietary factors are if you have a diet that's low in the folate, or lycopene fruits. I'm gonna spell it Lycopene. So if they are not eating foods high in folate or lycopene fruits, Lycopene, fruits and vegetables, I should say, they are at increased risk. So you say, Miss H, what are these foods? Never even heard of this. Think some of the foods that will help prevent it, or if you have a diet that's high in this, that will help prevent pancreas cancer, are going to be your tomatoes, watermelons, and pink grapefruit. Now you've got to be careful of that grapefruit, right, with all your other medications. Tomatoes, watermelons, and pink grapefruit are some great foods high in folate and lycopene. Some of our signs and symptoms: we may have weight loss, back pain, or epigastric pain. A lot of times that pain is described at night as a gnawing or boring type pain. The pain gets worse at night and is a gnawing or boring type pain. Oftentimes they will have some bowel and bladder color changes. So oftentimes their stools become light colored or even a clay color. So stools become light in color or even clay colored. And the urine becomes dark. They kind of do the opposite of what the norm is supposed to be. Dark or pea colored. And there's oftentimes going to be a fullness after they're eating. Some of our diagnostic is going to be the serum ALP, which is one of our liver enzymes, glucose, and bilirubin, all three of which are going to be elevated. So elevated blood serum ALP, glucose, and bilirubin. Amylase and lipase levels we're going to check, but those are typically only going to be elevated if it's like secondary to pancreatitis. So those are still specific to pancreatitis. But if the chronic pancreatitis is the cause, those may also be elevated. Our blood coagulation test may also be altered. Then you also have the carbohydrate antigen 19-9. This is a tumor marker present in pancreatic cancers. So the carbohydrate antigen 19-9, also abbreviated CA 19-9, is a tumor marker that is present in pancreatic cancers. And then we have a lot of our other same things, CTs, MRIs, PET scans, biopsies. If you know, you know, Grey's Anatomy. Prognosis for pancreatic cancer is often poor, because it's not normally really diagnosed until it has metastasized. So poor prognosis. We almost always are going to treat with a surgery. Surgery can be curative if we remove all of the cancer, though it is oftentimes still followed up with chemo and radiation just to be sure they killed all the cancer cells. We also will, this is one of those ones we will do palliative to sometimes reduce the signs and symptoms that may occur from it. So the Whipple procedure is also, I'm not even gonna try, y'all already know. I wrote out the full medical term for it. Not even try, not even gonna try. It is a complex surgery. Basically, in this surgery, they remove the head of the pancreas, lymph nodes that are nearby, common bile duct, gallbladder, and most of the duodenum, however you want to say it, and even parts of the stomach. So a lot of the GI organs are getting cut off. So it's a very high risk, extensive surgery. Do you think the Whipple surgery is most likely going to be a palliative surgery? No. Always, typically we try least invasive to most, so it can be done laparoscopically, but it has sometimes does have to be a full open procedure. Our risk for any kind of surgery in the GI, especially one of that extent, is if the sutures don't hold, and therefore enzymes, bile, excessive things leak out into the abdominal cavity. And then we have a lot of post-op problems like infection, etc. A distal pancreatomy is going to be removal of just the tail or part of the pancreas. And the total pancreatomy is very rare, which will also remove part of the gallbladder, or removal of the whole gallbladder.
Is it gallbladder?
A total pancreatomy will include the total pancreas and the gallbladder, all of the gallbladder. If there's a biliary obstruction, we can get some relief by placing a stent. We're going to watch for any kind of malnutrition or imbalance, especially after the surgery of that extent. So prior to surgery, we're going to consider any malnutrition. Remember what I said, protein is your building block, so we may get an albumin. If they don't have good nutrition, are they going to heal well? How extensive and spread of the cancer is it? Is this even going to be a well-considered treatment? And then also our complications going to be infection number 1, they officially form, as well as malabsorption syndrome, meaning that they are not absorbing nutrients at all. And thrombophlebitis, meaning, what is that? Someone break it down for me. Thrombo is what? Clot, huh? A clot? A clot. Like a clot. Thrombo meaning clot. Phleb meaning. What's
Like a
phlebotomy?
vein.
Vein. What's phlebotomy? What is, think of what phlebotomy is. Phleb meaning vein, and itis is what? Inflammation. So typically a blockage has occurred in the veins, reducing our blood. All right,